Thank you. Thank you so much. Good morning, everybody. I really want to thank the American School Health Association for hosting this virtual event and inviting the Centers for Disease Control and Prevention to speak on this critical, challenging, and timely topic. As was said, my name is Commander Erin Sauber-Schatz. I'm an officer in the U.S. Public Health Service, and I have worked for CDC since 2009. I have a PhD in epidemiology, a master's in public health, and a certificate in public health preparedness and disaster response. I'm also a mom. I'm facing the same decisions as many of you regarding opening schools safely in the fall and ensuring the health and safety of our children, our teachers, school staff, their families, and the larger community. COVID-19 has also directed many of us here at CDC. The children of two members of my leadership team were unknowingly exposed to COVID-19 in just the last week. They're dealing with the stress and concern as they wait to see if their children develop COVID-19. They are also, of course, concerned for the well-being of the people who unknowingly exposed them and are currently ill with COVID-19. Even as we all experience this pandemic in our personal lives, CDC has been working 24/7 since we first learned of this outbreak, now pandemic, to respond to this public health threat. As part of CDC's response to COVID-19, I lead the Community Interventions in Critical Populations Task Force. Schools have been one of my task force's top priorities. We have been identifying gaps in guidance and knowledge and working as quickly as possible to address these gaps using the best available science. This is the approach that CDC is using to address the difficult challenges of how to open schools safely this fall. One of our challenges is that COVID-19 is a new disease, and we are learning more about it literally every day. I just heard last week that there have been over 56,000 scientific publications on COVID-19 just since January. CDC has a whole team of people reviewing every article that comes out to inform our next steps, what guidance we need to update, and what new concerns have been raised. Because the situation keeps changing, we are in a much different place today than we were even just 2 weeks ago. Now, as we all work together to help reopen our schools safely, we're trying to balance our renewed understanding of the benefits schools provide to children, families, and communities with what we know and continue to learn about how this new disease affects all of us and how we can prevent it from spreading. When our kids came home in the spring, we were all reminded of how fundamental schools, teachers, and administrators are to our children, our families, our communities, and our country. From an academic standpoint, extended school closures can lead to learning loss, and the need for in-person instruction is particularly important for students with specific intellectual, learning, and behavioral needs. Students who rely on essential education support services such as individual education plans, English as a second language instruction, special education, and learning accommodations are put at greater risk for poor educational outcomes when schools are closed. In addition, disparities in educational outcomes become wider. Some families cannot participate in distance learning due to lack of computers and internet access. They may rely on school-based services that support their child's academic success. The persistent achievement gaps that existed before COVID-19 closure, such as disparities across income levels and between different race ethnicities, can worsen and cause long-term effects on children's educational outcomes and health, and the economic well-being of families and communities. Students who rely on services such as school food programs, speech or occupational therapy, and after-school programs are put at greater risk for poor health and educational outcomes when schools are closed. Schools also play a critical role in supporting the social and emotional health of children. School interaction among children in grades K through 12 is an important component of every child's healthy emotional state and the development of strong language, communication, social, and interpersonal skills. Students may have experienced social isolation and increased anxiety while physically separated from their classmates and their school due to COVID-19. Getting back to school and in-person instruction can support students' social and emotional well-being. Further, schools facilitate social and emotional health through lessons and support systems that develop students' abilities to recognize and manage emotions, set and achieve positive goals, appreciate others' perspectives, and establish and maintain positive relationships and make responsible decisions. Schools provide critical psychological, mental, and behavioral health services like psychological counseling and mental and behavioral assessments. Due to school closures, these services may have been unavailable to children who need them. Lengthy school closures also can leave some students feeling isolated from important friendships and support from other caring adults. Furthermore, isolation and uncertainty about the COVID-19 pandemic can create feelings of hopelessness and anxiety while removing important sources of social support. Increases in anxiety and depression may occur when students do not have the structure and routine that being in school brings to their daily lives. Weighing the many benefits that in-person school provides with the risk of spreading COVID-19 is not an apples-to-apples comparison. As I mentioned, CDC is working to identify and fill gaps in our knowledge, and we are actively working to build a comprehensive scientific understanding of how COVID-19 affects children. Here's some of the information we've learned so far from our own work and the research of other experts. Early support suggests that children are less likely to get COVID-19 than adults. And when they do get COVID-19, they generally have less serious illness. While some children have been sick with COVID-19, adults make up nearly 95% of COVID-19 cases. I just checked CDC's COVID data tracker this morning. In the United States, we have 3,236,130 cases of COVID-19. 6% of the COVID-19 cases are among adolescents less than 18 years of age. The deaths are, as of this morning, 134,572 deaths. Among children, the death counts are less than 0.3% of COVID-19 related deaths. Reports suggest that numbers of COVID-19 cases among children may vary by age and race and ethnicity. Adolescents aged 10 to 17 may be more likely to be infected with the virus that causes COVID-19 than children younger than age 10. But adolescents do not appear to be at higher risk of developing severe illness from COVID-19. We are currently seeing a higher proportion of COVID-19 cases among Hispanic and Latino children than among non-Hispanic white children. But it's important to recognize that, like adults, children with certain underlying medical conditions are at increased risk of severe illness from COVID-19. Severe illness means that they may require hospitalization, intensive care, or a ventilator to help them breathe, and may even die. In addition, although rare, some children have developed multi-system inflammatory syndrome, frequently called MIS-C, after exposure to the virus that causes COVID-19. This is a serious condition in which different body parts can become inflamed, including the heart, lungs, kidneys, brain, skin, eyes, and gastrointestinal organs. Black and Hispanic and Latino children may be more likely to develop MIS-C than their white peers. Thankfully, most of the children hospitalized with MIS-C have recovered. Data on how COVID-19 spreads among children are limited. Evidence from other countries suggests that most children with COVID-19 were infected by a family member. For example, the first pediatric patients in South Korea and Vietnam were most likely infected from contact with an adult family member. Published reports from contact tracing of students with COVID-19 in schools in France, Australia, and Ireland suggest that students are not as likely to transmit the virus to other students compared to members of the household. Okay, so I've talked about the many benefits of schools. I've talked about what we know about the impact of COVID-19 among children. Now, I'd like to raise the question, how do we plan and prepare to open schools as safely as possible in the fall? Almost every state has plans in place for opening schools in the fall. But part of the challenge of further developing those plans is that schools have mostly been closed since mid-March. CDC and many other educational and public health partners have been looking to other countries to learn from their experiences. But many of these countries are in a different phase of the pandemic than we are in the United States. Internationally, schools have responded to COVID-19 using a variety of approaches. For example, China, Denmark, Norway, Singapore, and Taiwan all required temperature checks at school entry. Denmark was the first European country to reopen schools. There, they staggered students' re-entry in waves. One group started school first, followed by another group at a later date. They also limited class sizes and used social distancing measures that reduced the distance between students as spread in their country dropped. Students under 12 returned first based on their lower health risk and the need for more supervision than older students. Class sizes were reduced to allow physical distancing. In Taiwan, students returned to school with mandatory temperature checks and use of face masks. Rather than national school closures, Taiwan relied on local decision-making to determine if classroom or school closures were needed based on infection rates. There is mixed evidence about whether returning to school results in increased spread or outbreaks. For example, Denmark initially reported a slight increase in cases in communities after reopening schools and childcare centers for students aged 2 to 12 years. But that was followed by steady declines in cases among children between ages 1 and 19. In contrast, Israel experienced a surge of new cases and outbreaks in schools after reopening and relaxing social distancing measures. It is unclear what caused the increase in cases and what other mitigation measures the school had implemented. Evidence from schools in other countries suggests that school reopenings are safe in communities with low rates of COVID-19 spread. But many US communities are experiencing high rates of community spread, even record rates of community spread. This summer, my home state of Texas has reported more than 1,700 COVID-19 cases in childcare facilities. Of the 1,700 cases, about 500 were among children and 1,200 among staff. This means that there were twice as many staff members diagnosed with COVID-19 than children. I know this is not comforting information for those of you that work directly with children in these settings. This does, however, suggest that children may be at lower risk of getting COVID-19 than adults, but it also highlights the risk to adults, teachers, and staff. I would like to spend the remainder of my time giving an overview of some of the resources available from CDC Now that can help you, your schools, and your communities understand the variables where you are and make the best decisions based on your local situation. I also want to let you know that CDC is working to provide even more resources than the ones I'm going to discuss now. We expect to release more this week. And while I wish I could say more about our new resources right now, I want to assure you that we are working to provide you with more guidance and tools based on the best available science that we have. At CDC, science is our North Star. Everything we do is driven by science and our understanding of it. That is why when faced with an emerging unknown threat like this one, we expect to revise and expand our guidance as we learn more. One of the first things I learned at CDC was that it was okay and frankly expected to say, I don't know, when you don't have the answer to a question. But then our job is to bring the science and the data to bear to get the answers to those questions. With COVID-19, there's a lot that the world doesn't know yet, but we do know a number of strategies that can help us slow and even stop the spread of COVID-19. CDC's website is full of science and information and is continually updated. On CDC's website, we have many resources that provide specific information to help communities, schools, workplaces, and events prepare for and respond to COVID-19. We have worked to provide information on how to stay safe where you live, work, learn, and play. We have guidance and resources for childcare programs, K-12 schools, colleges and universities, youth sports programs, and summer camps. In developing our guidance, we look at two types of proven strategies that slow the spread of respiratory viruses. The first strategy is using pharmaceutical interventions, like a vaccine and therapeutic drugs. While there has been some progress towards identifying effective therapeutics and developing vaccines, we are still overwhelmingly reliant on the second strategy, community mitigation. Community mitigation activities are the actions that people and communities can take to slow the spread of COVID-19. They are activities that you hear about all the time. Wash your hands, avoid close contact with people who do not live with you, wear a cloth face covering over your mouth and nose when you're out and around others, cover your coughs and sneezes, clean and disinfect frequently touched surfaces, monitor your health, and stay home if you are sick. We know there isn't a one-size-fits-all for reopening plans for schools. School administrators and officials can consult with state and local health officials to determine how to put CDC's considerations into place. Schools will need to make adjustments to meet their unique needs and circumstances. Implementation of mitigation strategies and actions should be guided by what is practical, acceptable, and tailored to the needs of each community. CDC's considerations are meant to supplement, not replace, any local state, territorial, or tribal health and safety laws, rules, and regulations which organizations must comply. Sometimes people forget that CDC is a non-regulatory agency. We provide the best available evidence, and it's up to decision makers to take action on that information for the health and safety of all of us. Successful community mitigation involves stacking best practices, bundling or laying actions together to reduce the spread of COVID-19. Each intervention alone, like social distancing, frequent hand washing, cleaning and disinfection, and the use of cloth face coverings, provides some protection. It is the use of multiple strategies together that will really make a difference in school systems and their communities. With our current considerations for schools, we focus on layers of mitigation strategies that can help stop the spread of COVID-19. The first layer of protection is promoting behaviors that reduce spread, things we do at an individual level to protect ourselves and those around us. The next layer of protection is maintaining healthy environments. Then there's maintaining healthy operations. And finally, it's preparing for when someone gets sick. Schools can play an instrumental role in encouraging and promoting behaviors that reduce the spread of COVID-19 among students, teachers, faculty, staff, parents, and families. Schools can help do this by educating staff and students and families about when to stay home if you feel sick or have symptoms. Teaching and reinforcing healthy hygiene like frequent hand washing and covering coughs and sneezes. And ensuring adequate supplies to practice healthy hygiene behaviors, including soap, paper towels, tissues, disinfectant wipes, and for staff and older students who can safely use it, hand sanitizer with at least 60% alcohol. Or as my son likes to call it, so that I will trip up saying it in public, sanitizer. Teaching and reinforcing the use of cloth face coverings is another step. It's important to remember that cloth face coverings should not be placed on children younger than 2 years old. I would like to note that on June 28th, CDC posted a cloth face coverings considerations document that talks about the current evidence for the effectiveness of cloth face coverings. Schools can also post signs, make announcements, and provide other communications to reinforce the messages that I've just outlined. Adding on another layer of mitigation, schools can implement processes and policies to maintain healthy environments. This includes cleaning and disinfecting frequently touched surfaces, including door handles, sink handles, and drinking fountains. Discouraging sharing of items that are difficult to clean or disinfect, ensuring ventilation systems operate properly, and increase circulation of outdoor air as much as possible. For example, by opening windows and doors. Do not open windows and doors if doing so poses a safety or health risk, like falling or triggering asthma symptoms to students, teachers, or staff. Schools can also modify layouts by doing things like spacing desks as far apart as possible, or having students sit on only one side of tables spaced out. Providing physical guides such as tape on floors or sidewalks and signs on walls to encourage physical distancing. For instance, you can use guides to create a one-way route in a hallway. Schools can also close shared spaces such as dining halls and playgrounds. If you can't close them, consider staggering use of these spaces so that you can clean and disinfect them between uses. Also providing alternative options for food services. I know that schools across the country have become champions in the last few months in finding creative solutions to ensure that children continue to receive meals while they're not physically in school. I would like to encourage you to continue to develop and share innovative practices that can keep kids safe while providing essential services. Then you add another layer in our stacking efforts, actions to maintain healthy operations. These include considering offering options for staff or students at higher risk for severe illness, including older adults and people of all ages with certain underlying medical conditions. For staff, this might be to include telework or modified job responsibilities. For students, this might include virtual learning opportunities. Pursue visual group events, gatherings, meetings, and field trips, and be mindful of how you need to adjust PE and organized school sports. Identify small groups and keep them together. We refer this as cohorting. Many elementary schools already do this, where the same class of students stay together throughout the day with the same teacher. This will help keep students and staff groups as contained as possible by having the same group of children with the same staff during the day. Another thing is consider staggering schedules. For example, have different groups of students dropped off at different times. Designate a staff person who is responsible for responding to COVID-19 concerns. All school staff and families should know who this person is and how to contact them. Also implement flexible sick leave policies to enable staff to stay home when they are sick, have been exposed, or are caring for someone who is sick. If feasible, conduct daily health checks like temperature screening, symptom checking, or both for students and staff. Unfortunately, there will likely be times when staff member and students get sick. That is why our fourth layer is so important, having a plan in place for when someone gets sick. I know many of you are wondering what role testing should play if someone in your school gets sick or even before that happens. CDC has posted information and questions that should be considered when determining what role testing will play in your school plans. This resource is meant to supplement, not replace, any federal, state, local, territorial, or tribal health and safety laws, rules, and regulations which schools must comply. Testing to diagnose COVID-19 is one component of a comprehensive strategy and should be used in conjunction with all of the behaviors I've already discussed. Schools should determine in collaboration with the appropriate health officials whether to implement any testing strategy, and if so, how best to do it. At this time, CDC does not recommend entry screening testing. This is a point-in-time test, and we have, in this document that I've mentioned, we have all of the reasons why there are limited evidence in the effectiveness of this strategy. Again, I want to stress that implementation should be guided by what is feasible, practical, and acceptable, and tailored to the needs of each community. Symptom screening and testing are strategies to identify individuals with COVID-19. I want to reiterate, though, that symptom screenings will fail to identify a portion of those that have SARS-CoV-2. That's the virus that causes COVID-19. Symptom screenings are not helpful for the identification of individuals with COVID-19 who may be asymptomatic, which means they don't have signs and symptoms of COVID-19, or pre-symptomatic, which means they have not developed signs and symptoms yet, but they will later. Others may have symptoms that are so mild they may not even notice them. Children are more likely than adults to be asymptomatic or to have only mild symptoms. This means that even when schools have symptom screenings in place, or parents are doing symptom screening, some students with COVID-19 infection who can potentially transmit infections to others will not be identified. Symptom screening also will only identify that a person may have an illness, not what that illness is. Many of the symptoms of COVID-19 are also common in other childhood illnesses like the common cold, the flu, or seasonal allergies. In addition to screening and testing, contact tracing is an effective disease control strategy that involves investigating cases and their contacts, typically by asking individuals to isolate and contacts to quarantine at home voluntarily. While schools play a role in identifying students, faculty, and staff who have COVID-19 symptoms or who have had recently known or potential exposure to the virus, school staff are not expected to directly administer viral tests. In some circumstances, school-based healthcare providers may conduct virtual testing in their capacity as healthcare providers, such as in school-based health centers. Not every school-based health center provider will have the resources or the training to conduct testing, and accordingly should not feel compelled to do so. These providers can help link students and their families and staff to other opportunities for testing in the community. In addition to layering mitigation strategies, it's important to understand the levels of risk. Within our considerations document, we highlight that the lowest risk is when students and teachers engage in virtual-only classes, activities, and events. There is, of course, more risk when you convene small in-person class activities and events. In this scenario, groups of students stay together and within the same teacher throughout and across the days. In addition, students remain at least 6 feet apart and do not share objects in this scenario. The highest risk, of course, is full-sized in-person classes, activities, and events. In this scenario, students are not spaced apart. They share classroom materials and supplies, and they mix between classes and activities. As I noted before, school staff should educate staff, students, and families about when to stay home and how to notify the school when they're sick with COVID-19 symptoms and when they can return to school after recovery. As part of planning for potential cases, schools should designate an isolation room to separate anyone who has COVID-19 symptoms. Immediately separate staff and children with COVID-19 symptoms at school, and individuals who are sick should go home or to a healthcare facility. School nurses and other healthcare providers should use standard and transmission-based precautions when caring for sick people. Information about these precautions is available on CDC's website. I'm being cognizant of my time, so I'm just taking a quick look at what else I want to say here in my last 3 minutes. So inform anyone, another step is to inform anyone who has had close contact with a person diagnosed with COVID-19 to stay home and self-monitor for symptoms. Remind them to follow CDC's guidance if symptoms develop. Clean and disinfect areas used by sick people. If possible, wait 24 hours before cleaning and disinfecting. In accordance with state and local laws and regulations, school administrators should notify local health officials, staff, and families immediately of any cases of COVID-19 while maintaining confidentiality in accordance with the Americans with Disability Act. As part of your planning, you should anticipate COVID-19 cases in your school. You should also consider whether there are circumstances in which you might need to temporarily dismiss school and then reopen again. This is one of the biggest questions we're facing and trying to answer right now. How many cases in a school should trigger a closure? Part of the answer is it depends on the local context. A school with 100 students is much different than a school of 5,000 or 50,000. It's important to remember that when administrators make decisions about school closures, they should be based on the level of community transmission, whether students were in closed cohorts, and coordination and collaboration with local health departments. What I've shared with you today is an outline of the strategies and actions for schools to consider. CDC, and frankly, all of us in public health, recognize how difficult it will be over the next couple of months for administrators and faculty to figure out how to operationalize these plans and actions in their schools and communities and adapt if your local situation changes. CDC is committed to helping schools prepare, plan, and respond as much as we possibly can. These are unprecedented times, and protecting all aspects of public health is paramount. As I said earlier, weighing the many benefits of in-person schooling weighing the many benefits that in-person schooling provides with the risk of spreading COVID-19 is not an apples to apples comparison. From other countries, we know that schools can open safely in communities with low rates of COVID-19 spread. If we want schools to open as safely as possible in the fall, we need decision makers, states, and communities to prioritize the opening of schools in their decision-making now. In order to prioritize opening schools safely and helping them to remain open, we need everyone to do their part to slow and stop the spread of COVID-19. I want everyone listening today to know that CDC is committed to helping students, teachers, staff, families, and the larger community, and frankly our nation, to stay as safe and healthy as possible. At this time, there's no way to ensure a zero risk of infection, but we do have mitigation strategies that when used together help prevent and slow the spread of COVID-19. They are relatively simple and they are our best defense right now. So I will close by urging you to follow them yourselves. Stay home when you're sick, wash your hands often, cover your coughs and sneezes, wear a cloth face covering when you're out and around other people. Thank you for listening, and please be safe. Be well and take care of each other. We need everyone to do their part to stop this pandemic. Thank you.
Thank you.